So, good morning, members of the high table, and good morning, distinguished ladies and gentlemen. Professor Adeseye Akintunde is a distinguished cardiologist and academic who was born on Christmas Day in 1975 in the town of Ogbomoso, Nigeria. He began his education at Baptist Primary School between 1980 and 1986 and continued at Ogbomoso Grammar School between 1986 and 1992, where he excelled in science, winning many laurels. He studied medicine and surgery at the Obafemi Awolowo University, Ile-Ife, graduating on the merit list in year 2001. He completed his housemanship at the Wesley Guild Hospital, Ilesha, and had his mandatory NYSC at the Federal Staff Clinic in Yola. Professor Akintunde underwent residency training in internal medicine at Ladoke Akintola University Teaching Hospital, Oshogbo, earning fellowships from the two great colleges, National Postgraduate Medical College of Nigeria, as well as the West African College of Physicians. His academic pursuits took him to Germany as a DAD research scholar under the German Academic Estate Services, where he trained in cardiology and earned a Doctor of Medicine from the University of Tübingen. He is a fellow of the American College of Cardiology, the European Society of Cardiology, as well as the International Society of Hypertension. He began his academic career at Lautech in 2011 as a senior lecturer, becoming a reader in year 2017 and a professor of cardiovascular medicine in year 2020. His research focuses on hypertension, cardiovascular risk factor clustering, heart failure, rheumatic heart disease, and cardiovascular genomics. He has participated in major international studies such as the iron deficiency anemia in Nigeria with heart failure, the SIREN, the Inter-CHF trial, and the Invictus trial. He presently leads the Nigeria Clinical Lipid Research Group, focusing on lipid disorders in Nigeria. Professor Akintunde has authored over 130 publications, including journal articles, book chapters, and technical reports. He holds a co-patent and serves as a peer reviewer for multiple journals. His research contributions have earned him local and international awards and even scholarships, including grants from the International Society of Hypertension, German Academic Exchange Service, the Grand Challenges of Canada, and the University of the Western Ontario. And this does not stop there. He has also received our own TED Fund grants in several cycles between 2016 and 2017, year 2018-19, and 2023-2024. In administrative capacities, he has served as the acting head of the department, deputy dean, acting dean, and at present is the current dean-elect of the Faculty of Clinical Sciences at the Ladoke Akintola University Teaching Hospital. He is a long-standing member of various university committees and currently chairs the College Timetable Committee. Professionally, he holds several leadership and editorial roles, including Associate Editor of the Nigerian Journal of Cardiology, Editorial Chairman of the Integrated Journal of Medicine and Medical Sciences, and is a key member of the African Regional Advisory Group of the International Society of Hypertension. He is the course director of the African Hypertension School a school that trains non-physician health workers in hypertension management. And he also serves as the state coordinator of the Nigeria Hypertension Society. And presently, he is the publicity secretary of our prestigious society, the Nigerian Cardiac Society. His membership includes prestigious bodies such as the NMA, HASU. He's also a member of the Royal College of Physicians, Edinburgh. He's a member of the European Society of Cardiology, American College of Cardiology, and International Society of Hypertension. He is also involved in faith-based medical activities, such as being a member of the Christian Medical and Dental Association of Nigeria. So Professor Akintunde is married to his atrop, Dr. Mrs. Temitope Shade Akintunde, just to do like the person that read the earlier citation. So she happens to be my namesake as well. Who is an associate professor of economics at the Osun State University. They are blessed with 2 children, Toluwani and Temiloluwa. Professor Akintunde embodies excellence as an academic, clinician, leader, and family man. Ladies and gentlemen, with a standing ovation, can you please welcome with me to the podium Professor Adeseye Abiodun Akintunde, the guest speaker for this auspicious occasion. You're welcome.
Thank you very much, sir. Please sit down. It's extremely humbling to be here this day, and I'm going to express the way I feel in just a few statements as I start this lecture. I mean, I guess if Dr. Oluga said she's the first daughter, then you can imagine that I'm the first son. And like I said, it's a very great, I feel very highly honored to be here today to give this lecture on behalf of my very good boss. You know, there are bosses that you want to be like academically alone. There are also people that you want to follow in every other aspect of life. The person we're talking about is exactly that person I'm talking about today. So let's start in a few moments talking about this day. Mr. Vice Chancellor, the provost, the dean, head of departments, and every other protocol observed. I'm going to talk a bit about this in remembrance, to commemorate the valedictory impact of a great teacher. And it's titled, Resting, but Hearts Beats On, From Hypertension, Heart Failure, Celebrating a Life of Impact in Cardiology. Okay. You know, one of the things I noted in life is that teachers had a backbone of education. They shape minds, they inspire futures with patience, dedication, and great wisdom. Their impact reaches beyond textbooks. They instill values, they ignite curiosity, and they foster great dreams. Professor Oluwati FAMILONI obviously made significant contribution to cardiology, and that's exactly who we represent today. And I'd like you to, together with some of my other teachers that are here, I can see Professor Rukundade, many other of my teachers, just join me to give a very loud ovation to all of them for making a very big impact in the lives of all of us. We're exactly the one that you have seen many years ago. And we hope to continue this trajectory that you have brought us under. Okay. This is one. Next slide. Some of his key contributions actually include hypertension research, heart failure management, cardiac arrhythmias, and public health advocacy. I'm going to talk a bit about some of them. And permit me, because this is not working, you quickly join me as I go. Some of his academic contributions again include cardiovascular epidemiology in Nigeria, and he has focused extensively on clinical and community-based health research. He has significantly contributed in many aspects as it concerns World Diabetes Federation project, as many of the non-communicable diseases are interrelated and interwoven. Well, he is living not only in time, but on this path, a legacy of cardiology excellence, which we celebrate today. And this lecture will be given as a tribute to that impact of a great person in cardiovascular medicine. There is no doubt that Prof. FAMILONI has put his name on gold in cardiology practice in Nigeria and beyond. If you read the first page of his inaugural lecture given some few years ago, page 1 says, as the only cardiologist in this university, and indeed in the whole of Ogun State Public Service for over a decade, I have had to lay the foundation of cardiology training, both at undergraduate and postgraduate level, and also its practices in the university and teaching hospital. That's exactly an outstanding work that many of us have seen today. Let's look a bit at some statistics about heart disease. Over the world, cardiovascular disease remains #1 cause of death. By 2021, heart disease has accounted for almost 19.4 million deaths by that year. And in Africa, it's almost the second largest cause of death after infectious disease. Again, as you know, this continent experiences a rapid upsurge in epidemiological transition. There is every likelihood that this disease will take over infectious disease very soon. And premature death from people who have CVD before age 70 years are actually higher in Africa than in any other part of the world. Again, like you and I know, health challenges in our system remains a significant factor, including the fact that hospitals are underfunded, the specialists are on their way out, and we have limited access to even newer medications when they are available. By 2021, the Nigerian Bureau of Statistics suggests that cardiovascular disease was responsible for about 11% of all deaths in Nigeria, with hypertension being the commonest risk factor that affects about 30 to 40% of adults in our population. Again, urbanization is not taking but a very drastic trend on our environment, and you simply need to work out and see how urbanization is taking a toll on many of us, being unaware. Rather, the access to care and diagnostic facilities remain a challenge all the time. If you look at the world population, the matters of the heart is a major concern, because ultimately, as we grow ahead in these years, this disease will ultimately catch up with us. And there are very major predictions that suggested that sub-Saharan Africa are likely going to experience a rapid upsurge, not only in prevalence, but in mortality associated with heart disease. You know, somebody said, the heart is more than a vital organ. It is the rhythm of life itself.
Prioritizing heart health is not just a medical necessity, but a profound act of self-respect and care for others.
It symbolizes resilience, vitality, and the capacity to endure. And for someone that is deeply committed to that innovation, he must focus on heart health. And that only mirrors our dedication to sustaining not only our well-being, but also the energy that is required to drive this meaningful change. That's exactly what Prof. FAMILONI that we celebrate today represents. In this way, his commitment to heart health and innovations are therefore intertwined, and both as demanded from him great discipline, foresight, a deep understanding of the interconnectedness of the system, both biological and technological, requiring that he lays a foundation for a good legacy, not just on ideas, but on an enduring strength to bring those ideas to life. If you look at all this heart disease, particular hypertension, they are gateway eventually to developing heart disease. And when they persist, they eventually lead to heart disease. The question is, why does hypertension, why does it matter? It's not because of blood value, 150, 80, or 190 over. No, that's not the reason. The matter is that it can impact on your health. And it can impact on several organs in the body, including causing strokes, heart failure, heart attacks, and visual loss. The impact on a heart can include things like, like I said, heart attack can lead to heart failure over a long time, and then atherosclerosis, that is narrowing of the blood vessel, and that eventually leads to, what we call heart attack and angina pectoris. Again, it can impact on the brain, leading to strokes, and then cognitive decline, cognitive dysfunction, that is, memory loss and other things. It can impact on the kidney and eventually lead to chronic kidney disease. Hypertension is almost always either the first or the second commonest cause of kidney failure in this part of the world. Again, on the eye, if you look at the eye, you can see the impact of hypertension on people, as can lead to progressive visual loss over a long time. Of course, its impact on the vessels is quite outstanding because it can lead eventually to progressive thickening and narrowing of the blood vessels. And of course, many other disease, that's exactly what leads to peripheral vascular disease, that eventually leads in many, clients to maybe amputation in some parts, not in this part of the world. Of course, very important, hypertension can affect your sexual health. And a lot of times, the hypertensive subject is often worried about that. Sometimes they think that it's the drug, but even the disease itself can lead to erectile dysfunction as a result of reduced blood flow, especially, and then even in women, low libido in them. There are a lot of inventions that have developed over the years. And like I tell people, it is not impossible to not only prevent it, but to slow the progress of hypertension by the things we do. It stands on the tripod of genetics, our environment, and the things that we do. The genetics you may not be able to affect, but the things we do, the things we eat, the things, whether we are active or we're not active, can define what our life really becomes. So there are a lot of preventive strategies, and a lot of them are, of course, beyond the scope of this presentation, but typically, public awareness to make sure people are aware about the danger of the disease. And that's, I think this lecture will do that. Community outreach where people can be screened. And it's obvious, somebody can have hypertension for 20, 30 years until one day he suddenly develops a stroke. And in our part of the world, somebody will say, oh, that disease started overnight. No. These risk factors have always been there. The only fact is that they are not symptomatic. So we've got to look out for them. Community outreach. And then clinician community linkages. And then there are a lot of lifestyle changes, including dietary approach to stop hypertension, which basically involves reducing your salt, increasing your intake of fruit and vegetables, increasing your raw veggies, and increasing your physical activity. And of course, stress management is very important. There are a lot of work that has been going on in management of hypertension, and there are very many recent breakthrough treatments. And I'm glad to tell us that one of these actually emanated, somewhere in Nigeria. Unfortunately, we don't celebrate our own. I was at TSC, last year when Professor Oji from Abuja presented some results from the low-dose triple therapy, and it was such a great honor. So there are very many things. And maybe in the next 30 years, we will discover the total cure. But for now, there is no complete cure for hypertension. You need to be on your drugs, and some of these drugs, have to be used for life, or for at least a sizable period of time until properly advised, maybe on a drug holiday. The next thing to know is that these risk factors cluster together and they eventually progressively lead to involvement of heart disease. One of which we are studying today is how hypertension eventually progresses to heart failure. And if you look at this diagram that I've seen, it can take somebody from this stage to the end stage it can take somebody like 20 to 40 years. So on unexpected death, sudden death, as we see in our population, does not just happen. They are predated by long years and decades of presence and intertwining of risk factors. And it's our duty to identify those risk factors, to manage the burden of cardiovascular disease, and not to wait until those things evolve. So this diagram therefore presents to us opportunities for intervention at early stages before they eventually develop into a big quagmire like heart failure that are often difficult to manage. And like I said, in life, interventions are very, very effective in prevention. The only challenge is that it takes the wise to know. Let me give you an example of one of the interventions that have led to some of the things that we see today. In one of the publications from this hospital by Prof. FAMILONI, Professor Ogun, very revered Adeseye, some years ago, I look at a brief example of how intervention had actually led to heroic consequences. They noted that people that were living with hate at that year constituted about 4.2% of all medical admissions. And that between 1992 to 2001, it rose to 7.6. By 2002, it declined to 7.4. And they suspect, just a few years after, that decline was possibly from introduction of highly active antiretroviral therapy. If you look at the profile of some of the information of some of the patients, next slide please. Some of the patients that were in that write-up, they had very strange presentations like age-related complex, age-indicator disease, and mortality. A lot of them died within 6 months. Many of you will know that a lot of our patients with HIV/AIDS do not have this today, simply because art has become a norm, except in this day of evolution of the Trump, agenda that possibly will cause a decline. But it's almost a normal, like treating hypertension, like having HIV, because the patients are fairly doing well, and I can't remember the last time that some of those patients were admitted with many of these complications. So you can imagine what that simple intervention had actually led to. It's a reflection of what we can do to prevent heart disease in future. And that is simply, reflected in this pictogram, by the CDC, as the number of people that are taking highly active antiretroviral therapy increases. The total reported HIV prevalence incidence in the world is actually on a decline. That's an intervention, and that is a reason for an action that can be taken. Of course, in another study, by our very own, they looked at knowledge, attitude, and at-risk behavior for heart disease among secondary school teachers in Ibadan metropolis. And you can imagine that, that study was a joint study by, thank you, ma'am. What they did was simply looking at the knowledge, attitude, and at-risk behavior that were for heart disease. And you can imagine the outcome. They assessed the respondent knowledge and found out that there were a lot of misconceptions, especially among children, and hypertension. Majority of them correctly identified cardiovascular disease to involve heart and blood vessels, but their overall attitude towards heart health was regarded as very poor. A lot of them were also unconcerned about heart disease. And you can imagine that 73.5% of our respondents justified smoking. That's as bad as their knowledge can carry them. And I can tell people, whether you smoke by holding a stick in your mouth, or you stay beside a smoker, you are a very good smoker too. Because you are simply a passive smoker that takes even possibly more than the person exhales. So you are not only a risk, you are possibly at a double risk of heart disease by staying around smokers. So you can imagine how our knowledge affects what we do. They concluded from that study that there is a need for health education among secondary school teachers, only to improve their knowledge and modify their risk behaviors. And addressing this gap is quite important. Of course, they brought this also into play in the CK research group, a very major funded study for which Prof. FAMILONI was a part, together with Prof. Alebioshu and others. They looked at awareness and knowledge about diabetes mellitus and hypertension, which are the major cardiovascular risk factors in secondary school in Oyo State. And you can imagine what their conclusions look like. While looking at about 894 respondents, they discovered that more of the people who are health club members in that group, in that study, reported a higher knowledge of many of these diseases compared to people who are not members of the health club. And that, overemphasizes the fact that knowledge plays an important role in prevention, in detection, and in development of the disease. And if you look at that graph, all of the people who are members of the health club demonstrated consistent knowledge about many of these cardiovascular diseases because they took time to learn them. And obviously, it will affect their attitude, it will also affect what they do, and prevent this disease, obviously, in the future. Like you and I know, OETH sometimes at one point became the Nigerian capital of QT research. And that's exactly what brought me here. My national dissertation was on QT, and I'm very glad to have met Prof. FAMILONI at that time. I just made a call, and you can't imagine making a call to somebody that never knew you, and agreeing to supervise you on a part 2 dissertation. I felt it was a great welcome, and I was very sincerely thank you for I would have enjoyed that relationship. It's somebody that calls, he says share, and I enjoyed that privilege. In a study reported in 2008, the QT intervals and outcome of pregnancy in patients with eclampsia were reported. And the impact was to study the pattern of QT interval and dispersion among patients who had eclampsia. What that study revealed was that a lot of the subjects had many of these QT parameters prolonged than normal controls. What it means in average sense is that these are risk markers that can be used to identify people who are at risk of developing a disease. We're talking about prevention here. We're talking about using markers that could prevent somebody from developing a major disease. And that's why QT becomes a very important mark of cardiovascular mortality. Again, another study reported recently in 2001 studies about relationship between P-wave dispersion, left ventricular mass index, and function in Nigerian hypertensive subjects. It was shown that there are people who have P-wave dispersion actually had prolonged QTC, and it correlated significantly with the severity of left ventricular mass. What that means is that the more the weight of the left ventricle, the higher the likelihood of your increase in this QT. And when you pick somebody's QT, you can literally almost say that this person will be at risk, this person will be at a bit of a lesser risk. When another study looking at the community-based diabetic risk assessment in Ogun State, that's the World Diabetes Foundation project, usually also in the CARDIOLOGY project, they look at assessing people for developing diabetes, using a particular risk assessment. And their conclusion, again, is, important to listen to. It says that the risk of developing diabetes mellitus is high in the community, especially with females having a higher risk score. And there is therefore an urgent need to implement diabetes prevention strategy. What it means is that whether the things we do or the environment that we live in has made us continuously predisposed to developing some of these risk factors. And it's important to take time not only to educate ourselves about the disease, but to take actions to prevent them and also mitigate the complications that will come right from there. And I think it's one of the things that many of our bodies are shouting about, especially in a country where, GDP is relatively low and, we've become almost a poverty capital of the world. In the sense that when this disease eventually evolves, their management may be costly, but they can be easily prevented by adequate preventive measures, which include simply lifestyle adjustments and many of the things that can be done without much cost. Well, sometime in 2012, we also published Privilege, QT interval prolongation and dispersion, epidemiology and clinical correlates in subjects who are newly diagnosed systemic hypertension in Nigeria. And what we show is that people who have hypertension freshly, by the time they were coming to the clinic, actually had prolonged QT. In that study, 52.1 of newly presented hypertensive already had QT prolongation. That's to say that they already have an increased risk of cardiovascular mortality. And it's also fairly more among females, with mean age between 55 years and their blood pressure as high as 154.3 milliliters of mercury. That's an urgent call for concern. Simply because even by the time somebody is coming to an hospital and he claims the hypertension was just diagnosed 1 year ago, there are already templates for risk, cardiovascular risk in them. And it is important to note that they must be taken care of appropriately. When another study to look at the effect of hemodialysis on QT interval and QT dispersion in patients who have had chronic kidney disease, they showed that those patients have a high hospital mortality rate, but that the mortality possibly was related not only to QT but to their late presentation. That's a very major factor in our part of the world. And we're burdened with several alternatives that don't work. And these are the things that we must tackle daily to encourage early presentation and effective treatment. People who are pregnant also have significant cardiovascular morbidity and mortality. And in a study reported in 2004 by Prof. FAMILONI and others, they showed that those who had pre-existing hypertension actually tend to have a worse prognosis compared to those without hypertension. In fact, literally all the people with pre-existing hypertension develop preeclampsia. And that suggests that heart disease is a continuum. Once you have one, you must be careful of the others. They stay together, and there's no need to deny it in the name of, whatever. It's important to address this problem and address them, holistically. Like I said, QT intervals they are important in many diseases and have been shown to be useful in several conditions. Looking at the impact of QT intervals and dispersion in patients with acute ischemic stroke by this same author, Prof. FAMILONI, he showed that those that had ischemic life changes had a significantly high proportion of QT changes, T-wave inversion, U-wave, and almost 43.8 had QTC mark prolongation. These are people who possibly could develop ventricular arrhythmias and other, issues about sudden death, if care is not taken. And they concluded by saying that ischemic-like and repolarization of VCT changes are common in our patients with acute ischemic stroke, and that these changes may actually related to pre-existing heart disease. In other words, they highlight the potential of a disease that's progressed over time and that has led to an involvement of a continual, risk that can be modified by what we do or what we do not do. But one of the markers of risk factors in diabetes is what we call cardiac autonomic neuropathy. And in some group of patients, they identified that those with cardiac autonomic neuropathy actually have a significant risk compared, with those who do not have. And that there was a twofold increase of developing that disease, especially when serum creatinine was greater than 1.5 milligram per percent, or when the fasting blood sugar was significantly higher. Also highlighting the fact that this disease always exists in clusters. You're talking about heart disease, you're talking about kidney disease, you're talking about diabetes, you're talking about hypertension. All of them leads to a continuum of disease over the years. In another study of patterns and factors affecting outcomes of heart failure, they showed that the majority of patients were in the wet and the cold congestion category. That study was published sometime in 2007. And when I was reading this article, one thing that amazed me was that this distinction of wet and cold category in heart failure was just introduced in the University of Cardiology guideline on heart failure, maybe about 5 years ago. So I was wondering that my boss already had that appellation before the ESC actually picked it, 5 years ago. Unfortunately, we don't celebrate ourselves. But this publication was in 2007, and it got to international guideline just about 5 or 6 years ago in the wet and the cold category. Thank you very much for a good job, sir. Let's look again at how, I simply showed that this disease is a continuum, and that interventions has been shown by the work of our revered teacher today, that intervention can lead to a modification, not only of the outcome, but of the progression of the disease. But let's go back to how can hypertension lead to heart failure? How does it occur? You see, the mechanism that, occurs when your blood pressure is about to be controlled is multifactorial. It's not only a factor of how much drug you take, it's limited to many things, including your lifestyle, including your genetic factors, including your environmental factors, including, the drugs that you take. So you don't take it one and take it, I think that's all. What you eat, if you're hypertensive and you keep taking rubbish, it's going to be difficult to control your blood pressure. You can also reduce the burden of drug that you take when you do appropriate and adequate lifestyle adjustment. And like I said, there is a range of heart disease that can evolve over the years, and it takes time. From left ventricular hypertrophy, the left ventricle continues to increase in weight, obviously eventually leading to impairment in relaxation ability, and eventually leading to impairment in contraction. Sometimes there is a bit of variation in both genders, but what is obvious is that the mechanisms appear similar, and it says that there's a lot of increased fibrosis in the heart vessels, there's a lot of oxidative stress, there are very excessive inflammation, and very many biomarkers come into play. Of course, there's a lot of vascular adaptation that also occur, and those adaptations eventually tend to stiffen our vessels, make it more stiffened. So it's like the heart continues to pump against a tighter or a less elastic wall. And that increased arterial stiffness is the pathophysiology of hypertension and other disease that occurs there. Of course, there are a lot of macroscopic changes that leads eventually to heart failure. They include things like, the left atrium begins to enlarge, the left ventricles begin to hypertrophy, and after some time they dilate and then they fail. And then there is a lot of systolic dysfunction. There's also what we call dysynchrony. There's also torsion, and of course a lot of accumulation of microscopic mitochondria. But there are cellular factors, and many of these are not they're not unrelated to the neurohormonal mechanism, the renin-angiotensin-aldosterone system, the sympathetic nervous system, and that's actually the drug that actually decides on what we use when you're managing, this disease. So it's important to note again that this progress over time, and it leads to left ventricular remodeling, and then arrhythmia can evolve, then heart failure can also evolve. And that's why typically you tend to have that these risk factors often start in the middle age, and by the time people are getting to 67 years, the proportion of people with these risk factors possibly will be quite enormous. Well, there are very many other things that are caused, including development of flash pulmonary edema, increased left ventricular diastolic pressure, and increased salt and water retention. But of course, that eventually, may lead to development of, cough and other symptoms that may evolve. Yeah. Several drugs have actually been, brought into play in reducing the burden and, the impact or development of stroke. And, there's no time to mention, but there are a whole range of drugs that is to reduce not only your blood pressure, but to reduce your risk of developing heart failure and stroke. So when you actually manage hypertension, what you are simply doing is to reduce your risk factors for developing stroke. And you can imagine, some drugs as much as 20%, and some drugs reduce it to as much as 28%. In the IVF study using indapamide, in the olden days we used to think that the older you get, you don't need to, doesn't matter your blood pressure is because of it. Now we know, doesn't matter how old you are, even if you are 700 years, and your blood pressure is 150/90, you still possibly require treatment. But in the IVF trial, that is hypertension in the very elderly trial, the use of indapamide has shown that the use of that drug has achieved a significant reduction, not only in heart failure, but also in non-fatal and fatal stroke. And if you compare indapamide to clothalidone, these are non-targeted, diuretics. There is a very small, relative reduction, but both of them actually are useful. And in meta-analysis, you can find that indapamide appears to be relatively better than clothalidone. In this biomarker project, what they did is to use appropriate cardiovascular risk factors to predict the risk of developing heart disease. And it's an European Union project to assess the value of emerging biomarkers to develop cardiovascular risk and for its prediction. Of course, these are the main points, and these are some of the components of those risk markers. That study included more than 80,000 participants, and it took place in several parts of Europe and a few other parts of the world. You can see that risk factors like triglycerides in almost all the studies consistently show that the hazard ratio is in the excess of 1. What it means is that when your triglyceride rate triglyceride values increase, you have an increased risk of developing heart disease. Simply what that means. The rate at which it occurs may vary on many other factors depending on the presence of others. Let me end by saying that Prof. FAMILONI is not just an academic, like I've just been talking about papers and publications, since a few moments ago. It's a man of many parts. And, you can see, he's a wonderful family man. I just wonder, very handsome. And, you know that he doesn't look 70. I'm sure you agree with me. Yes. Thank you very much. He's a very wonderful family man. You can see several pictures showing, and you only need to interact with him. You will know that, he's a very jolly good fellow. He's also an advocate for health. He's done several work in the, with the Seeking project. That's diabetes and interrelationship and interconnectedness with non-communicable diseases in Nigeria. He's presented several papers, publications in several parts of the world, and his work still speaks till today. He's also an international fellow. He's been in several parts of the world, and yours sincerely was very privileged to stand with him, at the ACC those years when he was becoming a fellow. His commitment to God's word is also unequaled, and is also very enviable. He has an undying passion for God and His word. Like you have known or have heard, he's the Southwest Regional Coordinator for the Full Gospel Businessmen Fellowship International, and I admire his passion. Sometimes I ask him, I wanted to, but maybe the exuberance of the whatever has not allowed me now. I'll talk to him. After this lecture. So as I conclude here today, let me say that in the ever-beating world of medical sciences, your legacy pulses with purpose. And my only prayer is that may your journey ahead be as remarkable as the lives that you have touched. Amen. And that just as the heart sustains life, your knowledge and passion have sustained countless futures, including ours. Today we celebrate not just a professor, but a life giver. Today we honor a candle whose flame will continue to guide generations of cardiologists to come. And as we close this chapter, let's raise our hearts and voices, not just in applause, but in deep gratitude. And here is to your brilliance, Prof. FAMILONI. May this be just the beginning of new readings and deeper joy. Thank you, Prof. FAMILONI, for your great investment. We deeply celebrate that. Thank you very much. Thank you.
Please, we can make it louder. We are celebrating a life of purpose. That was brilliant. It can only come from the product of Professor FAMILONI. Thank you. Please be seated. I have the honor to invite again the Deputy Vice Chancellor Admin, Professor VALEDICTORY, to help us honor our guest speaker today, Dr. Adeseye Akintunde, as he presents this plaque to him. Professor Akintunde, kindly step forward.
Distinguished ladies and gentlemen, I have the honor on behalf of the Vice Chancellor to present this plaque, a word of appreciation to the guest lecturer on this occasion, Professor Adeseye Akintunde. Thank you very much, Prof.
Thank you, sir. You can be seated. Okay. Thank you so much, DVC. While the lecture was going on, we got another list of people to appreciate. I want to call Dr. Tunji Folarin, National Director Emeritus, Full Gospel Business Fellowship International. We appreciate you, sir. Seated beside him, Professor Olatunde Oweye, HOD, Anatomy, College of Medicine, Ibadan. Also a member of Full Gospel. And also there, Dr. S.A. Adeniro, a National Director of the Full Gospel Business Fellowship. We appreciate you. And also we have Architect Sam Adeyemi, also a National Director of Full Gospel. We're glad to have you here with us. For those who are familiar with this terrain, wherever you see Professor Familoni, you see Professor Adelowo, and one more person. His name is Professor Yomi Ogun. Please stand up for recognition. It's a world-class neurologist. Okay, there's a seat here for you so that the three of you can continue. They will always say, whatever we know today, Prof taught us. So, sir, you still teach us. Also, with us, Dr. Aaron Ajibode, we appreciate you. Professor Alaba Adebola, a cardiologist at LASU, we appreciate you, sir. Professor Elohe Dani, former provost prof. Okay, he's somewhere around with us. We also have Dr. and Mrs. Badebo Saba. Are they still around? Okay. Mrs. Oshiberu, we also appreciate you. Okay. Professor Oshinobebi, we appreciate you, ma'am. And also Pharmacy Saka, Director of Pharmacy OOUTH, we appreciate your presence here. The Secretary of Afemiolo College of Health Sciences, Dr. Ms. Yetunde Ogosonwo, we appreciate your presence. The Acting Director of Nursing OOUTH, Mrs. Folashade Fawale, we appreciate you. The Deputy CMAC, OOUTH, Dr. Ibukun Ogundele, welcome. Director of Finance and Accounts, OOUTH, Mr. Muiwa Adekombi, we also appreciate you, sir. And all the former students of Professor Familoni present here today, please can you signify wherever you are, all the former students, even if you are